To shift gears a little to glaucoma. And so Dr. Odayappan is at Aravind Eye Hospital and currently involved in clinical research in the field of glaucoma, and he's been working on a family glaucoma screening program for the past 5 years. He's also very recently completed a micromasters in clinical epidemiological research at the University of Michigan.
Thank you, Priya. Today we'll be discussing about our review, finding the compelling the evidence for family screening in glaucoma. As we all know, glaucoma is the most common cause of irreversible blindness worldwide, and the numbers are projected to increase to 112 million by 2040. Screening for cataract is quite simple, where a simple torchlight examination is sufficient worldwide, and the numbers are projected to increase to 112 million by 2040. Screening for cataract is quite simple, where a simple torchlight examination is sufficient, whereas the same for glaucoma is not so, because it needs evaluation of multiple parameters like intraocular pressure, the angle assessment, the optic disc evaluation, and the visual field estimation. So population-based screening for glaucoma would be cost prohibitive. So what do we need? We need something called the opportunistic screening. That is, we target high-risk population. Now, who are these high-risk population? Various reports have shown that family history is a risk factor for the development of glaucoma. Now, the aim of our review is to compile these evidence together and see how much of a risk factor it is, and find out the different methods by which family screening is being conducted and the effectiveness of these programs. So we included studies which described primary pseudoexfoliation and pigmentary glaucomas. Mainly, they should have described either the response rate of the family members or should have given the prevalence of glaucoma amongst these family members. So since this was a scoping review, we followed the PCC framework, that is the Population Concept and Context Framework, and we searched across multiple databases including PubMed, Embase, Scopus, Web of Science, Cochrane Database, Epistemonicos, and Google Scholar, and ultimately we had more than 3,000 articles. But because we had screened through multiple databases, there were a lot of duplicates, and once we removed them, we had 2,000 for screening the title and abstract. We used the software Ryan to do this, and after that we had 52 articles which had to be read full text, and after that we had to eliminate another 13, and finally we had 39 articles for data extraction. Now the duration got prolonged, so we repeated the database search in February 2025, and we had 3 more articles, and finally we had 42 studies for data extraction. So these are apparently normal patients, rather people. They do not seek eye care. So we need to find a mechanism to catch these people and get them to the hospital for screening program. So these are the various methods by which the relatives were contacted across the various manuscripts. So we'll see a few. So for example, in 2014, Dr. Sharmila et al. Published this article with the role of postal letters. That is, if they posted 100 letters to the relatives, they found only 7 of them came to the hospital for the screening program. And the main reasons was that they attributed this was there was a low awareness about glaucoma, and there was migration of family members to other places. So then came the concept of motivational cards. That is, this is a study comparing the role of motivational cards with that of oral counseling. So what they found was oral counseling was in fact better, rather than just giving motivational cards to the primary patients. So the main disadvantage with these motivational cards is that these cards probably do not reach the intended target, that is their relatives. So then came a few other options like giving phone calls to the relatives. So this is one. The more pragmatic way would be to screen the accompanying person. Usually these primary people with glaucoma, they are not one-time hospital attendees. They are going to be repeated hospital attendees. Now every time they come, they are going to come with a fellow person, accompanying person, and who are usually first-degree relatives. Now every opportunity like this can be utilized to screen these relatives so that we can reduce the magnitude of irreversible blindness. And this is a randomized controlled trial from Nigeria where they had two groups. One group had just oral counseling, where in another group, in addition to the oral counseling, they also gave a phone call to the relatives and asked them to come to the hospital. And they found that those in the phone call group had 2.5 times more likelihood of coming to the hospital for a screening program than those who did not receive the call. And other methods that have been described include newspaper ads, text messages, or emails. And finally, when we pooled all these information together, we found that the pooled prevalence of glaucoma amongst relatives was around 11%. And another 14% were found to be suspects. In all, 25% of the relatives either had glaucoma or were identified as suspects. Whereas when we compare that with the general population, the prevalence is just 3.5%. And when we look specifically at the relationship, we see the prevalence is more amongst parents and siblings than in offsprings. But this could be misleading because glaucoma is a disease of aging. So parents are more likely to be glaucomatous, whereas the offsprings need not develop glaucoma at that point of time. Probably if they have followed up like 10, 15 years later, they might develop glaucoma earlier. So a study in China by Kong et al. Had identified this age-adjusted prevalence and found that offspring and siblings had 11 times higher risk of glaucoma if they had a family history, whereas parents had a 7 times higher risk. So what are the various barriers that I have described? Primarily, it is because they perceive themselves to be normal. They do not seek eye care. They do not want to take time off their work and come to the hospital for a screening program. And some are residing in far remote areas that they cannot travel to the base hospital for a screening program. And in some cases, it is that the proband do not want to reveal their details to their relatives, mainly to siblings. And in a few cases, the relatives could not be contacted. But a generalized overview is that there is poor awareness about the familial predisposition of glaucoma. So the lessons learned, we know family history is one of the most important risk factors for the development of glaucoma, and there is poor knowledge among relatives, there is poor communication between the relatives, and the response rate to glaucoma screening programs are fairly poor. On a personal front, I learned to do a proper literature search according to the different frameworks, and then we had to use Ryan and Covidence for data screening and data extraction. And we also analyzed how to do inter-observer agreement, calculate the Cohen's kappa. So it has been a very good learning experience for me over the past 1.5 years, though it has been quite long. And the main challenges that we have is that database access. So only 2 databases are available for free, the PubMed and Google Scholar. All other databases require institutional access or they are quite too expensive. And then it is quite time consuming because it's a very iterative process, and sometimes it becomes like quite boring because we need to repeat the same things again and again. And during the course of the review, we see new information also coming up, which needs to be added to the existing results. And again, that might consume a little more time. So the steps taken, family screening is now an integral part of our system. Like we have devised a new software which is capable of sending automated SMS and voice message to the relatives. And so any proband who comes to the hospital, their relatives are informed to undergo a free screening program in our hospital. This helps in bypassing the communication gap between the relatives as well. So thank you.
Thank you very much. So I'm just going to open up the floor for questions. Srinivas? Okay.
Nice presentation. Great work. Just 2 quick questions. You have 42 studies.
Yeah.
Okay. So all these studies from different parts of the world are.
Yeah, predominantly they were from India, Nepal, Nigeria, and China.
So did we get any information on consanguinity?
No, most of the studies have not described about consanguinity, so we do not have data on that.
I think that's one thing that we can always look at. Place the regions where you have consanguinity versus the regions where you don't have consanguinity. What would be the prevalence?
Yeah, maybe in future prospective studies, they need to include that in their data extraction forms as well. Yeah, thank you.
Yeah. Just get
So this is a software that we have devised. What we need to do is we need to enter the relatives details, the phone numbers, and we have devised a system where this is linked to a communication tool which gives an automated message and voice call also, asking them to come to the hospital for a free screening program. Yeah, the person who was initially diagnosed to have glaucoma, who is the proband, he needs to give the information to the counselor. Now, sometimes it so happens that they do not have those details. So in that case, we ask them to collect the details and we can call them up next day and then we can remotely enter this information into the system. Now, when we click save, the message automatically goes immediately.
Wow.
Parikshit?
That's
Last
impressive. I just wanted to make a comment. We had done a case control study published about 10, 12 years ago, looking at early presentation versus late presentation. So that is 0.8 or more cupping. Now, in the Barbados eye study or all over the world, if you have a family history of glaucoma, you are more likely to be an early presenter than a late presenter. In Pune, we had at 2 places, those with family history of glaucoma were equally more likely to be late presenters. So that means either their doctor did not take the time to tell the proband that you should get your check, or as you said, that the proband did not tell his family members, or that.
Yeah.
That's one. And the second is, again, Barbados study, the UK studies have shown that if you have visited an eye care practitioner in last 2 years, you are less likely to be a late presenter because the optometrist or the ophthalmologist has picked up your glaucoma. In the Pune study, even visit to an eye clinic was not found to be protective for late presentation.
Interesting. I'm just aware of time. If there's one last burning question. Yes, there's a hand up at the back.
Very excellent work. I just wanted to know whether is there any specific mean age that was mentioned in any of the article of the family members that were screened for glaucoma?
Yeah, that's what we wanted to look at as well, but that's a very wide variation. Quite a few studies have included all relatives more than 5 years of age. Some have even not mentioned the age group of inclusion, and a few have restricted to 40 and above. But that's widely variant between the different studies.
Okay, and the second one is the family members. Is there any particular generation that they have included, like first generation family members or second generation, like?
Yeah, in most cases, they have restricted to first degree relatives. There are a very few which have included second and third degree relatives as well. But predominantly, it's either just siblings or all first degree relatives.
Okay, thank you.
Thank you.
So I'd just like to say thank you to all our speakers. I hope, Ruchi, you're inspired to do more operational research after your past 2 days here. And Uday Kumar, I think the clear theme that comes out in all 3 of your research is that making behavioral changes is very hard. We, as clinicians, most of us focus on our practice and how good the quality of our clinical skills are. But I think we really need to start thinking from a much more public health perspective that behavioral change is much more important to make sure that the right outcome happens for the patient. So thank you very much for your various research.
Thank you. Thank you. Thank you very much.